Good afternoon. Thank you for joining us for this Google Plus Hangout. My name is Michael Gerson. I'm a fellow at the One Campaign, which is a grassroots organization dedicated to the fight against extreme poverty and preventable disease. And I'm also a columnist at the Washington Post. I'll be moderating our discussion today. Our Hangout today is going to focus on the President's Emergency Plan for AIDS Relief. PEPFAR is the U.S. government's initiative to help save the lives of those suffering from HIV/AIDS around the world. This historic commitment is the largest by any nation to combat a single disease internationally in history. In fact, PEPFAR is now treating about 5.1 million people worldwide with life-saving antiretroviral drugs. 2 days ago, PEPFAR celebrated its 10th anniversary with an event hosted by Secretary of State John Kerry, and there was a remarkable announcement at that event. Due to direct PEPFAR support, 1 million babies have been born HIV-free. This is really one of the best examples in American history of the way that the properly focused foreign assistance can make a life or death difference in the rest of the world. And it's also a common ground commitment in America across two administrations and with support from members of Congress from both parties. To discuss PEPFAR's progress over the last decade and answer questions that have been submitted through Twitter using the hashtag AIDSFreeGen, I'd like to introduce Ambassador Eric Goosby, U.S. Global AIDS Coordinator. Ambassador Goosby oversees the implementation of PEPFAR, has more than 25 years experience with HIV/AIDS, ranging from his early years treating patients at San Francisco General Hospital, where AIDS first emerged in the US, to engagement at the highest levels of policy leadership. Welcome, Ambassador Goosby. And joining us today are also Jennifer Cates, Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation, Dr. Linda Gail Becker, Deputy Director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine, and Chief Operating Officer of the Desmond Tutu HIV/AIDS Foundation, and Tatu Msengi, a nursing officer in charge of the Kilimanjaro Christian Medical Center in Tanzania. Tatu eloquently told her story of being an HIV-positive woman who gave birth to an HIV-negative daughter 8 years ago, thanks to the PEPFAR program, at the 10th anniversary event at the State Department this past Tuesday. I'm going to go ahead and direct the first question to you, Ambassador Goosby, and then I want to open up the floor to the other participants for their comments. Please don't be shy. A lot of the questions we received surrounded one set of issues. What does achieving an AIDS-free generation mean, and is it really realistic?
Well, I'd be happy to start, Michael. Thank you for putting this program together, and thank you to all the participants. Secretary Clinton in November of 2011 began to articulate the concept of an AIDS-free generation. This is an idea that the science has enabled us to begin to see the light at the end of a tunnel. It's a way for us to conceptualize the progress that's been made in our ability to contain the movement of the virus, not only in an individual, but also through communities. An AIDS-free generation is specifically referring to the fact that if you are HIV negative, we want the prevention interventions to have targeted you to minimize your high-risk behavior so you never become HIV positive. If you are HIV positive, we want you to have access to diagnosis of your HIV seropositivity and then to be able to initiate the elimination of opportunistic infection and then the antiretroviral therapy, the cocktail. With the initiation of therapy, progression from HIV being HIV positive to a diagnosis of AIDS with the development of an opportunistic infection or a drop in your T cells less than 200 will be preempted. I think that the idea that we can keep people from becoming infected, If you are HIV positive and pregnant, we can prevent the transmission from the mother to the baby. And altogether, this gives us an opportunity to hold HIV, contain HIV where it is, both in the individual and to prevent its movement to others who are HIV negative. So preventing an AIDS-free, creating an AIDS-free generation.
Well, maybe we can hear from some of the others, both on the treatment side, which has been a huge success of PEPFAR over the last 10 years, really beyond expectations, I believe. But also on the prevention side, the next generation of prevention. Maybe we can hear from some of the other panelists.
I think the creating HIV-free generation has been possible since the PEPFAR starting supporting African countries. As you can see, I'm here as an example that PEPFAR brought happiness to me by getting the HIV-free child, Faith. And creating HIV generation means bringing happiness to many HIV positive mothers, so the family get back to life and continue with their normal life with the help of PEPFAR. So creating HIV generation is possible, and it has been possible since PEPFAR has started supporting African countries.
Michael, perhaps I can jump in to say that I think it's already been said, the important aspect of PEPFAR is that it has incorporated both treatment and prevention, not creating a false dichotomy between the two. And that we have this very important notion that treatment sits alongside prevention. And as Eric has already alluded to, that AIDS is the consequence of poorly managed HIV. And so this notion of reaching an AIDS-free generation is the early detection and successful treatment of individuals, but also the opportunity to prevent HIV in those who are not yet infected. And I'm very excited that we now today really have a number of tools that if we implement properly, we can really reach out for an AIDS-free generation. And I believe that PEPFAR in our PEPFAR countries has laid that foundation to enable us to do that. And so, you know, the point that I want to make is that in order to reach an AIDS-free generation, we have to bring treatment along and prevention along equally using our evidence-based mechanisms. And I've watched the last 10 years of PEPFAR. I'm very excited to see that we are now entering this new era where we start to implement the tools to reach those fantastic visions and ideals of reaching an AIDS-free generation.
Dr. Becker, what are those tools briefly? I mean, what is the range of interventions you're using in that area?
Well, you know, we've heard some exciting evidence-based 3 randomized controlled trials showing that male medical circumcision reduces acquisition of HIV to an uninfected male partner. And PEPFAR is also putting, again, resources behind rolling out male medical circumcision. Very important intervention, which is a one-time intervention that just shows benefit on an increasing scale. Of course, the prevention of mother to child, which we've already heard from our colleagues, is so important in order to both reduce illness in the mom, but to make sure that baby is born HIV uninfected. The notion of using treatment to bring down community viral load is also now being tested in large scale. But we do know that amongst discordant couples, if one positive partner is virally suppressed, taking their treatment well, the uninfected discordant partner is protected from HIV acquisition. And you know, there are other prevention tools that we're learning to use, particularly in reaching out to key populations and highly affected, hard to reach populations, that I think is going to turn the epidemic around. And I'm confident that if we apply these tools with the gains that we've made through PEPFAR, we have a good chance of doing it.
Jennifer, you have anything to add there? Go ahead. We're not hearing you. Okay, I think we'll have to come back. Let me raise one more question, Eric, for you, that comes from the Twitter questions that we've gotten in a variety of variants. How is PEPFAR helping empower countries to respond to the HIV/AIDS epidemic? I know that this began as an emergency program, but there's been a transition in the program over time towards a more sustainable model. And how has that progressed, and where are we in that process?
Well, I think that, Michael, you're correct in saying that the initial focus for the leadership with PEPFAR was to stop the bleeding. And there was a high priority to rapidly deploy capability, put it on ground, and literally add to the implementing armamentarium of the country with multinational NGOs, with using country resources, but also bringing additional resources in that created effective but created parallel systems. Toward the second part of PEPFAR, so in the second phase of PEPFAR, seeing the debulking of inpatient-dominated responses, so where you'd have hospitals that were full of people in late-stage disease coming into medical care, the ability to identify people earlier and target them in their communities before they develop real symptoms has enabled us to now look at how do we maximize our ability to sustain these programs for as long as they're needed, which is going to be decades. Our focus has been in trying to capacitate the country to be able to oversee and manage, monitor, and evaluate the programs. Our ability to work with ministries of health, ministries of finance, as well as presidents of countries to prioritize their investment, their willingness to invest in the systems that early identification require and in systems that retain people in care over time. We've worked with ministries of health to create the information systems around laboratory and human resources that are necessary for policymakers and allocation decision makers to be able to prioritize unmet need and make appropriate allocation decisions along those lines. In addition, countries we've spent a great deal of time defining the country's contribution in human resources, bricks and mortar, as well as money to treatment, care, and prevention services, so the countries understand and are empowered, skin in the game, to be additive with resources like Global Fund and PEPFAR. So I think this has been truly, it sounds like common sense, but it's been a huge shift in how we do business as the United States government, how we relate to our partner countries' leadership in allowing decisions to be made that were normally kept within the USG, and to still hold ourselves accountable for retention of the quality of care as the transition to more country-led and operated programs moves forward.
Yeah, in the early days of PEPFAR, I saw some of that, where PEPFAR had their program guy in Namibia, for example, sat in the office right next to the health minister.
That's right.
And worked together on a single country plan. That was a genuine partnership rather than, international institutions coming in and telling people how to work.
Very true.
A different approach in many ways, and I think a very positive one. Let's open it up to others on this issue of partnership and the assumption of responsibility by countries themselves. I know that's happening in South Africa and a lot of other places in pretty dramatic ways.
Michael, I can jump in just to say that, this notion of sitting and working with countries has also gone right through PEPFAR 1, 2, and now in the transition, where I've been particularly struck that PEPFAR administration has worked very closely, for example, with the South African government to ensure that there is alignment. That is one of the key principles of the South African PEPFAR partnership, is alignment, not with necessarily the blueprint of PEPFAR, although obviously we are very much applying the blueprint in terms of attaining an AIDS-free generation. But there is also a real need to align with South African principles and where South Africa wants to go. And I'll say this, that, you know, I'm very proud of my country in that we have achieved enormous strides in the last 10 years, very much assisted significantly, of course, by PEPFAR, Global Fund, and other aids. I've heard it described by somebody that, you know, we've gone from polecat to poster child. And, you know, I think this is something that the emergency, the E of PEPFAR, is so critically important to South Africa, where lives were initially lost unnecessarily, but now lives have been extraordinarily saved. And we have to build on those great achievements going forward. South Africa needs to do it, and South Africa can do it. But, you know, again, not forgetting the very important foundation that PEPFAR has provided in reaching for those goals.
Jennifer, we're having a little technical issues, but can you hear me? I'm not sure she can. Okay. It's a shame because she's one of the best voices on this issue, and I would love to hear from her. Yeah. Tatu, can you give me a little perspective just on, from a Tanzanian perspective, of the way Tanzania has taken on some of these responsibilities, the faith community there, the government, and others?
Yeah, government have starting to take responsibility, as now we have a local run organization called the Ariel Glazier Pediatric Healthcare Initiative that works in collaboration with the Elizabeth Glazier Pediatric AIDS Foundation, and it has started to work on one region, and we have planned to scale up the services. So Tanzania have taken the initiative to make sure that creation of HIV generation is done by African, to show that they are struggling to save their fellow Tanzanians, to give the PMTCT services, to offer care and treatment services with the partnership of ECPAF.
Fantastic. Let me raise another set of issues, which are too broad for this discussion, but at least we can touch on them. This is also raised in the questions we received up by Twitter. Do PEPFAR programs target women and girls in a particular way? And if so, how does it do this? Eric, maybe you can address that.
Sure, Michael. You know, I would say that PEPFAR has not had to go out of its way to target women and girls. About 63% of the people who we see in our care, prevention, and treatment programs are women and girls. Women and girls are those who come to the clinics, take advantage of the services. Often we are capturing the woman as the first entry point into the broader family through antenatal clinic services. And women just in general are play a role in our families, in our societies in which we work, that puts them out there as the caregiver and the individual that identifies the service needs for their family. We believe that when we capture a woman in care and embrace her in services over time, her children and her partner are much more likely to be embraced in care and services as well. We see this over and over and over again. So we are firmly committed to looking at barriers to accessing care for women and other key populations that need special consideration for identification and retention.
One follow-up there, Eric. Men, in my experience in visits there, often get treatment later. in this process. Why is that, and why has that been a problem over the years?
You know, there's something about men that does not want to present themselves to medical delivery services in just about any culture you want to look at, including the United States. I think men are given messages very early on to endure and persevere in a way that allows them to make those decisions for themselves. And if I could be so bold as to say, men are not in the orchestrating role for children and other family members as they are burdened by a disease process. It's usually the women. And the men usually listen to the women. But interestingly, men in all of our country experience are late to come into care. Once in care, there are issues around retention that are more challenging. It often has to do with the fact that men are in work situations that pull them geographically into different areas. They become migrant and need to retain those jobs to keep the money flow for the family. So there are those types of pressures. But I think there's a fundamental difference in the way men view themselves and their relationship to disease and getting treatment for it that really is the culprit here.
I'm interested in the other panelists on both of these issues, the special challenges for women and girls and also for men.
Well, I would pick up just to say that obviously, and again, some of the listeners may not know that in the PEPFAR countries, women have been disproportionately affected by and carry the burden of the HIV epidemic. We're not entirely sure why that is. It's likely it's a mixture of social as well as biological factors, but putting our prime focus on women and girls is clearly what we do need to do. However, I think it is important to recognize that PEPFAR has by no means ignored the male component in the equation, and this has been very important. And I think it's reflected in the HIV counseling and testing programs, where I think some real innovation has occurred to try and reach men who in that setting are the hard to reach population. Eric is absolutely right. Men are reluctant to come to our very woman-oriented facilities. They're run by generally female nurses. They largely are geared towards the matriarchal environment. And I think men are largely alienated by our health services. But there has been a real move to address that. I think I've seen that particularly in PEPFAR 2, but even prior to that, that there's been a reaching out to recognizing that we are in the midst of a generalized epidemic, implying that this is driven by heterosexual sex, which means there's a male and a female involved. And therefore, whilst we put real attention into women, and we are actively looking for what that combination prevention package is for young women, because clearly that's the bang for the buck. If we can stop young women getting infected, that's going to turn the thing around. But at the same time, their partners tend to be older men who perhaps the power balance is in their favor, but we need to address reaching out to those men as well and coming to them with real services that address their needs where they are. So I think in PEPFAR, I've seen some of the HCT programs, the male circumcision programs are much more than just circumcision. They really are bringing comprehensive care to men and reaching out to men. And I think we'll start to see more engagement around men.
Tatu, what have you seen on this set of issues in Tanzania that relate to women?
I think PEPFAR have targeted even male, female and girls, because in some institution in my country, despite of PMTCT services, we have a clinic called the Child-Centered Family Clinic, where we have youth club. So youth club, we can find there girls walking in for HIV testing, and they access treatment. And not only girls, even we have started targeting males, because we have youth there. Our target is to build the confidence to men so that they can have access to HIV care and treatment when they grow up, and encourages other means not to diverge and walking into clinic free.
No, that makes sense. That makes sense. Okay, let me raise another topic here, which is how does PEPFAR work with faith-based organizations, which I've seen on the ground, Eric, often have a lot of trust in these communities, but sometimes not the scale that's necessary to address some of this. But how is PEPFAR related to the faith community in dealing with these issues?
Well, thanks, Michael. I think I'm glad you bring this up because the faith community, faith-based organizations specifically, have long track records in countries, in most all the countries that we're working in. And the added utility of faith-based organizations is they are sometimes in capitals of countries, but they more often than not are in rural settings that are, kilometers away from capitals and give us that extra reach as PEPFAR moved from immediate response into scaled responses that required that there be a geo-distribution of resources that allowed for testing, staging, initiation of treatment, and targeted care prevention interventions outside of the capital city. So faith-based organizations play a critical role in the PEPFAR portfolio in every country we're in. Their ability to be part of the larger national response using the same first-line drugs, having that formulary part of their formulary, taking advantage of the cost reductions by buying in large scale, having laboratory support for monitoring labs, using the same reagents and lab tests, has created some dialogue in virtually every country early on in PEPFAR. That's all been worked through now, and largely there is a much more harmonious alignment with the specifics, the implementation specifics of putting program on ground with public versus faith-based sites. Critical role, we need them. That's why we are partnered with them and will continue to partner with them.
Any other thoughts on that issue about the cooperation, not just between governments, but between government and community and faith institutions in Tanzania and South Africa?
Sure, Michael, I'm happy to say that in the faith-based organization group, I also put community-based organizations, which have been really very key to the scale-up and the rollout, particularly of antiretrovirals, and then programs for orphans and vulnerable children, and then, of course, the PMTCT scale-up as well. And it's those faith-based organizations that I think we've seen incredible transition. In our own environment, we've seen nuns who have gone from running very much care and support programs to actually becoming very expert at handling and handing out antiretrovirals in a very effective way. And so that we've seen during PEPFAR 1 and 2. And those organizations have been absolutely key in getting the scale up that we've required. You've already said, and I think this is very important, that they are deep in the country. And we know that HIV, really does need to be met at the most rural, at the most primary healthcare level in order to be successful. And I think we've only reached the kinds of scale up we've reached because we've gone into those deep CBO and faith-based organization type reaches deep into community. I think the challenge has been, as we transition now to handing over more to government care, is what exactly is the role again of faith-based organizations and how do they fit in? And I think we are still very much in that phase of recognizing the role that of hope and moral support and backup that comes with faith-based organizations and realigning them in a way that is supportive of what government needs to do. And I think that is the sustainable model. As we are in this transitional phase, I think we haven't yet worked everything out. And that is to be noted and to be recognized and to be celebrated in some ways. We are going through the transition. I'm absolutely convinced that the CBOs, the FBOs have been there since the start of the epidemic, and they will continue to be key. My own patron referred to this as the new apartheid, recognizing that people who lived with HIV were marginalized and highly stigmatized. And, you know, it's the early response to HIV-infected people that the faith-based organizations brought that has been so important and will continue to be important as we move into this phase of sustainable response to HIV and AIDS.
Tatu, is that your experience as well?
Yeah, I think faith-based organization has a great role to play in combating the HIV/AIDS situation, because we serve the same community, whether it's a government organization or a faith-based organization, community-based. All of us, we serve the same community. So the faith-based organization have given a great chance, and they have a large role to play in saving the population. And sometimes we can see that in faith-based organization, people can work more easily than the government organization, and their resources are distributed equally. So they have everything to save the population that the government are saving. We are depending on them because we can't depend on government organization alone, and we want them to have the same services that anyone walks in can get services as the same services one can get in government organizations.
Okay,
Michael, I'd like to, if I could add one more thing, if I may. I think faith-based organizations also play a very important role on this continent, and I'm South African, as you noted, and African at large, is around key populations. So populations that are marginalized, and particularly here I'm thinking of men who have sex with men. I think, you know, again, the faith-based organizations have been important in recognizing stigmatized populations and bringing them in. And again, I think there is a key role here. I unashamedly put forward my own patron again, Desmond Tutu, who has been, you know, incredibly courageous in this regard and has stepped out to say, God loves all people under the rainbow, and, you know, he would not serve a homophobic God. And this exactly, I think, is the kind of message we need. And again, what faith-based organizations can bring as we move into this next phase of targeting key populations to make sure that actually we don't have, if you like, fires of epidemics still brewing as we work so hard amongst the more generalized epidemics, certainly on this continent.
Well, we're reaching the end of our time, but let me raise that issue for you to address, Eric, at the end here of our conversation, because there are also questions here that relate to what PEPFAR is doing to promote access to and uptake of HIV services among LGBT and men who have sex with men, these populations. How is PEPFAR addressing those problems in particular?
Well, thank you, Michael. I think that PEPFAR's programs are there for those who need them. We have focused on trying to target populations that don't want or feel they can reveal themselves to authority and come forward on their own by creating a safe space within the medical context that allows individuals to not be confronted by how they got the disease so much as now with the disease, what services do you need? Faith-based organizations that have jumped to the need definition, as Linda was pointing out, as Reverend Tutu has really been quite eloquent about, are those that I think are best aligned with demonstrating to the broader society, the broader community, the true meaning of the humanitarian nature of the gesture, responding to the needs of individuals as they present them without a judgment element. The medical profession is not asked by society to make those type of judgments, and it always serves to decelerate identification and retention in an individual or a family if they feel that energy in their accessing of medical services. So we believe that we are there for the service and without qualification deliver that service. We also understand that if special considerations are not given for identification, entry, and retention for these communities, that they are often lost to care at higher rates. And the data show that the individuals who are participating in high-risk behaviors that are not embraced by the larger society come in with later stage disease and, as I say, are not retained in care over time. We've gone to great efforts to work within institutions, within communities, to try to create those safe spaces. We have put up what we call challenge grants to our USG colleagues and agencies to match from central funding in Washington resources that will match programs that do these special identification and retention strategies. We've also created a foundation of about $20 million in research that will allow us to better understand through implementation science some of the better practices that do identify and retain these individuals over the long haul, which is the duration of their life.
Great. Well, let me conclude just by thanking everyone who joined us on this Hangout today. And thank you for submitting questions, which were, I think, useful. I want to thank Ambassador Goosby, all our other participants for a lively discussion. This is really something pretty extraordinary that you're a part of, all of you are a part of, and that I admire so much. I mean, it's a partnership of the U.S. government, of governments themselves, of NGOs, of faith-based institutions to reach some very marginal people in our world. And it is a moral achievement that I think all of you should be very proud of having a part in. It's not, we still need to maintain this commitment, but it is an amazing thing that we are now closer than we thought we would be to an AIDS-free generation. And so we need to take that next step. Thank you all for joining us today.
Thanks, Michael. That's great. Really nicely said.